Ross, I know you have some skepticism about that post-hoc analysis.
Well, so Mark and I were chatting. So one of the issues is in that age-related analysis, there was no difference at all in the response rate as influenced by age. And although there was a numerical difference in progression-free survival, there was no statistically significant difference.
Small numbers, but you're exactly right.
Yeah. So the worry is this huge and completely unexplained effect in terms of overall survival, which is obviously to some extent further away from your intervention, your Nab-Paclitaxel, makes me a little suspicious. If you do Corey's study, what would your primary endpoint be? Would you have overall survival as the endpoint?
That would require a fairly large study to do. I guess if you made the assumptions, I'm blanking on what the survival was in the quad trial.
The median survival for weekly taxane, weekly paclitaxel, 3 weeks out of 4,
right,
and monthly carbo is roughly 10.5 months.
Yeah, so well, you'd
about
be looking
the same as the control arm
right.
in your trial.
Yeah, so I guess it wouldn't be necessarily a big trial because you'd be looking for a big difference.
Yeah.
So
I don't think we'd achieve 19.5 months, but
no.
even 15 months. Or,
no, but if you wanted to look for a 50% improvement in median survival, that would obviously that wouldn't take a large number of patients.
And then, of course, it's not the same schedule.
Correct.
And that's actually going to be sorted out in upcoming randomized phase 2, looking at
in the elderly.
In the elderly,
yeah,
a 3-week on, 1 week off schedule, a la Croix, the French trial, and then the alternative schedule will be an uninterrupted schedule, as you've piloted and ultimately studied in the phase 3. Govardhan and Alice, do you share Ross's skepticism?
Partly, Corey. I think Nab-Paclitaxel is an option for our patients, and the way I see it is that it's very convenient in terms of administration, no need for pre-medications. And the response rates, the differences are intriguing, but I think we should keep this in the context of where we have seen higher response rates that have not necessarily, translated into huge clinical benefits across the board. But I really think we should be spending our effort on more important questions to move the field in a significant way rather than comparing the schedules of 2 different agents. So it's an option for patients.
You would focus more on the molecular fingerprint of squamous rather than...
Absolutely. And also there's one thing intriguing about this Nab-Paclitaxel, the high response rates you see in pancreatic cancer, not the focus of our discussion today. It shows that it is not taxane, it's something more than that, and we still haven't fully understood that. And I think that we should spend some time studying why and how it works. I think that's an important, part of our research portfolio ought to be.
Alice, you mentioned at one point that your institution doesn't typically use Nab-Pac.
Yeah, well, certainly in my practice, I have a lot of non-squamous patients, and for those patients, we aren't typically in using it, but I've been very happy to have the option to use Nab-Paclitaxel for patients who can't tolerate steroids, for patients who might already have underlying neuropathy, and for patients who actually have a hypersensitivity reaction to paclitaxel.
One of the interesting things, just in terms of sparing steroids, and this will come in later in the discussion, is whether a Nab-Paclitaxel-based regime might be preferential when using some of the immune checkpoint inhibitors, so you're not using the steroids to damp down the immune system.
Because of the avoidance of steroids, ideally, theoretically. Mark, there's plans to look at maintenance therapy as well with Nab-Pac, if you can discuss that briefly.
Yeah, we have several maintenance options. Maintenance is not commonly done in the squamous subset of population based on my experience. The trial that is just starting is a trial in which patients will get 4 cycles of the FDA-approved dose and schedule in squamous carcinoma. If you have stable or responding disease, you'll be randomized to stop or continue with maintenance single-agent Nab-Paclitaxel. So continuation maintenance, much like the JMEN,
the Paramount trial with
the Paramount trial with pemetrexed.
So analogous.
Yeah, a similar trial design, specifically in squamous.
It goes on indefinitely. It's not a truncated duration.
No, it's not. Obviously, we know even with Nab-Paclitaxel, there's going to be a risk of cumulative side effects, particularly neuropathy. Most of the data would suggest that the neuropathy you see tends to be more reversible with this agent than with solvent-based taxane. So I'm sure, I don't know the trial intimately, but I'm sure there are stopping rules for excessive toxicity in that.
And the weekly regimen itself will probably mitigate toxicity compared to our usual Q3 week solvent-based taxane.